All right, everybody. Looks like the recording was working from what I saw on the little pop-up that came on my side. So let's go ahead and get started. Move this, make sure you can all see. Please let me know if there's any issues with the screen share. It looks like it's okay on my side, but sometimes hard to tell. So welcome, everybody. My name is Mariana Sears. My pronouns are she, her. I'm a safety net licensing manager with the Behavioral Health Administration. Learned a lesson from last time and tried calling in the way that it worked for our January 28th event. So please let me know if at any point the sound gets a little bit wild for me in Zoom. It tends to not get along with my computer very well. We are here today to discuss withdrawal management focus work group efforts as we look to essentially formalize withdrawal management services in the crisis space and to be able to ensure that we know what this transition is going to look like into our aligned provider roles. This is and again, we're about halfway there. We have 53 participants, so hopefully we get a few more here. But with this recording being available, we will make sure that everybody has access to this after the event as well. So a couple of housekeeping items. We have about 90 minutes together here today. We are recording the slide deck, and again, we had that technical issue at the beginning. Fingers crossed the audio works out now that Mel stepped up and is doing the recording for us. We are planning to post this deck and the recording on the BHA Laws and Rules webpage. For those of you that have looked at the website recently, that is, you'll find these recordings under the past ASAM meetings section about halfway down the page. And we are also planning to email this to the registrants of today's event. So just a quick heads up, because this might look a little bit different than some of our communications so far, if you already have been part of this space. We may be able to, at this point, transition over to Gov Delivery for some of these communications going forward, so that way it will just look a little bit different, but I wanted to make sure to flag that in case somehow that goes to your spam or a different part of your inbox, to make sure to look there. So it will either be from Gov Delivery or the way that we've communicated so far, the BHA rule feedback email. And I am getting some kind of interference here. Please make sure, if you have not already, that as you log in, if you don't mind muting yourself, and then if there's something that you want to share, either raise your hand or come off mute, and we'll get to you from there. We also have the chat feature that is available at the bottom, and I believe a Q&A was supposed to be available, hopefully on your side. I do see it. So, and Mel from BHA is going to be helping to monitor those chats and keeping this discussion on track as we go forward. All right, let's go ahead and keep going. So our agenda for today, within the next 90 minutes, we are going to do a little bit of level setting to make sure that we're all joining this discussion at the same point, recognizing that last time that we held one of these events, we do have new folks that are joining at different points and different levels of awareness of this transition. So we are going to back up a little bit to make sure that we all catch up and start from the same place. We're going to dive from there into some outstanding questions and concerns, and that will be a goal for this call, is to answer as many of those questions as we possibly can. We're going to align crisis and treatment continuum requirements together, and then we're very excited to officially and formally welcome our Transition Ambassador program and be able to kind of pull that together into this transition space, as this is a program that we've been really looking forward to helping help our state transition seamlessly into the 4th edition of ASAM. And we'll wrap up with some next steps. All right, so taking a step back, doing some of the level setting, the what and the why. The 3rd edition of the ASAM criteria is no longer the current standard for substance use disorder involved services. And let me go ahead. Oh, thank you, whoever needed that. So what we are doing right now is the state is positioning to align with the 4th edition of the ASAM criteria standards. So this is an interesting volume of rules or expectations. Sorry, I don't know if people are getting that alert I'm joining the meeting. Did not have that turned off, my apologies. So this is going to be a a process that will last for several years to truly get to full alignment with the fourth edition of the ASAM criteria. And that is because this particular criteria is being released in multiple volumes over multiple years. So the first volume that has been released so far is the adult version. And so everything that we're talking about here today is really leaning into that first edition, the adult volume of the fourth edition criteria. Sorry, I said that very strangely. But know that within the next couple of years, we will be coming back as other volumes of the fourth edition are released and aligning with those. That's going to include adolescent and transition-aged individuals, criminal justice involved standards, as well as behavioral addictions between now and 2029, I believe. So why are we doing this? Part of this, we have multiple requirements around this. Statutory requirements, which are referenced here, if you would like to dig a little bit more into those, as well as this is a requirement and a commitment that we made for our federal funding. Colorado does participate in the 1115 demonstration waiver. And in order to be eligible for that reimbursement model, we need to be in alignment with the most current version of the ASAM criteria. And then overall, this is considered to be the national best practice, and we want to make sure that we are providing the people of Colorado the best possible care, and really leaning into this as an opportunity to hopefully grow and actually strengthen our behavioral health system for everyone. Okay, so here is our main goal for today and what we're going to come back to here. Thank you. So I know our folks from the BASO were not able to attend today, and that is another one of the reasons why we wanted to make sure that we could record this and ensure that we're all on the same page and moving forward. But one of the things that we really appreciated from our last call when this particular group got together was being able to have an open discussion of wanting to be able to myth bust and to be able to look at things that people are hearing. Are these true? Yes or no? Do we know yet? And making sure that we're on the same page and moving forward. So what we have here is a list of a handful of myths that we hope to bust today or confirm or deny. Also some outstanding concerns that if we cannot necessarily answer everything today, we want to be open and transparent of what we are working on and the timeline that we need to get that situated. So what we've heard over these past few months, loud and clear, we heard there were concerns about the transition timeline needing to be revisited, that more time and more information is really needed for informed decision making, that there are significant logistical concerns that are part of this alignment, construction, permitting, questions about IMD requirements, and then really leaning into what are the base expectations that we would be moving towards here. So do all residential level of care need to have on-site withdrawal management services? Do all residential levels of care need to begin accepting 24-hour admissions, similar to how 3-2s operate right now? And then really, what are the pathways that our standalone 3.2 and 3.7 management providers have to choose from? And then finally, the last one that we have bulleted out here for today that we're hoping to answer is whether or not crisis-involved facilities are expected to offer these withdrawal management services. So we will come back to this as we go through the presentation and hopefully be able to check most of these off the list. Okay, so let's do, how did we get here? We're going to walk through kind of what the timeline has been up until this point, and then we'll talk about where we're going. So 2023, January, ASAM announced the plan to transition into the fourth edition. In July of 2023, Colorado announced the plan to continue our imminent behavioral health entity transition that we were undergoing at that time. We were planning to continue with the third edition of the ASAM criteria being that foundation for the behavioral health entity license. It would have been lovely if we could have at that time gone ahead and just aligned with the fourth edition and had all that change out of the way at once. However, it was way too significant of a change and there was no way that we were able to make those timelines work. And certainly for the state, that would not have been beneficial to be able to move that forward as rapidly as that would have required. So that is what we're doing forward is we've aligned with the third edition, and we are now continuing to move into the fourth edition. So November of 2023 is when the volume 1, the adult version of the fourth edition of the ASAM criteria, was released and became the national standard. And then January of 2024, our updated BHA provider rules took effect. And again, that was all based off of the third edition. That was a significant enough haul, moving from legacy substance use disorder treatment licensing and mental health designation into behavioral health entity licensing. And so one of the things that we built in was a delayed enforcement period, right, which was 6 months of really being able to only take action in cases of health, safety, and welfare, and then to really work on having more of a technical support approach for providers as they transition to this updated standard. So then fast forwarding a little bit, June and July of 2024, as a state, we announced the plan for targeting full alignment with the fourth edition of the ASAM criteria to be effective July 1st of 2026. This particular date was selected in alignment with the 1115 FUD demonstration waiver, as well as the state fiscal year, to make sure that we have an informed timeline for making transition. So I'm going to go ahead and go through this timeline here. This is the timeline that we've been operating on up until this point. So again, full alignment, we're going to work our way backwards, is expected to be July 1st of 2026, and that means that all providers would need to be have certificates and be providing services in alignment with that updated fourth edition standard beginning July 1st of 2026. So up until this point, in order to make that possible, we wanted to really take that approach, a similar approach with delayed enforcement. And so we were targeting a timeline of January 1st of 2026 to be when our aligned provider rules would be officially taking effect. So in order for that to be possible, that meant that we would need to be before the State Board of Human Services no later than the fall of 2025 in order to meet our traditional expectations for a rule promulgation process, right? 2 reads at State Board, a little month break in the middle, allowing some time for public comments and responses. So moving our way backwards, another kind of important highlight to mention, which is coming up very rapidly. We would be officially 1 year away from having that full alignment as of July 1st of 2025, which is also the same time that our BOSOs are officially stood up. So I'm going to do these last 2 bullets together because we are right kind of in the middle of these 2 particular parts here, right? Community engagement, which has really been more than just spring of 2025. We started having these discussions last year and continue to have these discussions as we move forward. But really this is meant to be over multiple months and hopefully bringing in multiple options for engagement. So far we've done a lot of virtual, planning for in-person work groups that are focused on specific transition needs. And so far it's really been prioritizing the most impacted provider types, which is this group that's here today. And then also as part of that, really bulleting out and starting to draft rules, seeing where our alignment and misalignment might be in statute, so we can figure out what are the potential barriers that we need to address next legislative session to make sure that we're on the same page and moving forward. So this is the timeline that we've been operating on up until this point. And again, going back to our goals of what we walk through today, one of the concerns that we have heard very loud and clear is there's concerns around this transition timeline. So this is very hot off the presses as far as a very recent exploration that we are starting to look at, but we wanted to bring you all into the starting point of that review. Based off of that feedback that we've received and looking at what all the work that we have ahead, we do have an alternate transition timeline that we are starting to vet right now to see if this might be a possibility and to help make this transition for the state a little bit more tenable going forward. So as I said, this is a new exploration, so there will be some more things that we need to figure out here. And I feel like I'm talking really fast, so please let me know if I'm going too fast and I will work on slowing down. So a bumper that we need to work within is that date of July 1st of 2026. This is something that has already been communicated to CMS. This really does fit with our 1115 demonstration waiver renewal. This is the targeted timeline and the goal that we want to achieve. The way that we get there, though, does not necessarily need to incorporate that delayed enforcement period, which was built in because it seems like it was helpful with the updated provider rules. But in this case, it may actually be, it may not be quite as helpful as having a little bit more time to work with us on the rules and make sure that we're moving forward in alignment. So for this proposed alternate timeline that we are looking at right now, this does not include a delayed enforcement period. Instead, what this does is it allows us to take the next few months to really work on community engagement, drafting of rules, and then really doing our full stakeholder process that would be connected to this in the fall. Again, feels a little bit less pressured. We get to the same end result, and but we have a little bit more support as far as being able to engage with the community and make sure that providers have all the support that they need to make this transition successfully. In order to have this aligned provider rules take effect July 1st of 2026, a little bit of a tweak that we would be making here is going to State Board of Human Services in spring of 2026. We don't have much of a buffer built in, but it does give us some more time to really work on getting this transition right, working with communities to make sure that they're supported and moving forward. We would still have our traditional rule promulgation process. That's going to be 2 different reads. The first one in March of 2026, ideally, and the second one in May of 2026. What we would need to do to make this possible is work with providers to ensure that between May of 2026 and no later than July 1st of 2026, that they have a transition plan in place that is solid, that aligns with what their services are going to look like in 4th edition standards. For some providers, that's not going to be a huge list. It's going to be looking at assessments that look a little bit different in the 4th edition standards. But for this particular community that we've really prioritized having interaction with, it will look different because 3.2 withdrawal management, as we know, is not going to be a standalone service anymore. We're going to be working these next few months to figure out what each agency wants to transition to and how to help to get to there. So really those 2 months would be primarily focused on ensuring that providers know what those expectations are, that we're able to do some type of a modified review process to ensure that there is compliance that would be in effect July 1st of 2026. And then transitioning to those 4th edition standards effective that date. So then working our way back so that you can see what that timeline would look like. Again, that means community engagement, the traditional feedback process and comment and response period would be closed by November to allow us time to incorporate that feedback, make sure that this goes to the Attorney General's office and is ready to go to State Board in the spring. Highlighting our all-important BOSSOs being stood up and our 1 year away mark for full transition. That date is still the same. But then this allows us to, again, we're kind of between these 2 bullets, so I'll have them both open at the same time. That continues to work on the rule drafting, a solid community engagement plan for the fall, starting now. So that we have that ready to go and we're able to provide the support that we're hearing from providers that we've not been able to give them. So I can't see a lot of faces, so I don't have a lot of nonverbals to go off of. I am going to pause real quick and just look at the chat and see if there's anything. Zach, I see that there's a comment in there. I'm going to go ahead and let Mel and some of my coworkers that are kind of helping on the other side do a little bit of chatting back and forth and figure out how to respond to that here in just a second. And Before I go to that, are there any questions specific, I think, to the transition timeline, this alternate timeline that we're proposing here today based off of the feedback that we've heard so far? Hearing none on that. Okay. So I want to move a little bit into the how. As we continue to vet that particular timeline to see if that is going to be more amenable and more more desirable for the state, and to make sure that we transition in a way that's more successful and seamless. One of the really exciting things that we can announce is we are standing up on BHA side a regulatory affairs unit. This is being stood up right now. This is a very kind of hot off the presses bit of information as well. And so part of this is really coming from the lens of over the past few years, there has been a lot of change, constant change, it feels like, and BHA became responsible for 3 volumes of rules. We have our provider rules, which we're talking about here today. We have systems rules, and we have administrative rules. There's recognition that in order to do this properly, we need to have a team that is dedicated specifically to regulatory affairs and moving this forward in a way that feels that is strategic and really responsive to what the provider community and the state needs. So right now, this particular unit is being temporarily staffed by existing BHA folks. So you might start to see some familiar faces and names in the next few months that are helping to work on getting these rules and this process, this community engagement plan put in place so that we can move this forward, hopefully in this fall. But then eventually this particular unit will be competitively staffed. So if anyone is interested or knows somebody who would be great at doing that, this is a unit that is being stood up right now that is intended to be a permanent fixture to ensure rules move forward appropriately. So the priority rule volume that we have right now and that we're talking through today, again, the 4th edition of the ASAM criteria, making that alignment, which also then overlaps with, I think there's a lot of familiar faces on here that are part of the Certified Community Behavioral Health Clinic or CCBHC planning grant. And so this particular unit will be looking at both of these parts of rule that need to be updated and helping support that over the next year. Going back to the how this will work with the ASAM alignment, Behavioral Health Administration, and again, this Regulatory Affairs unit will be the primary for rule-involved changes. And then we are partnering with Healthcare Policy and Financing to work on the residual impacts of that, right? Making sure that the rates are looked at, really helping the Transition Ambassador Program, which again, we're very excited to bring in officially today as well. Okay, I am seeing a number of chats that are coming in. I'm going to keep going unless something comes up that needs to be discussed right at the moment, and then we'll come back to chats and comments. So moving along here, we have a number of definitions and clarifications that are going to need to be made as part of this process. And one of the first ones that we want to start with is really making a distinction between intoxication management versus withdrawal management. So you will see an effort over these next few weeks to few months to really start to be cautious with our language and how we are using that. One of the bright lines that we see here and how withdrawal management services are currently operationalized across the state is really looking at that intoxication management, right? Individual is actively intoxicated, possibly involved with law enforcement, needing an urgent services at a 3.2 withdrawal management provider typically. And that is a crisis service that is being provided for that particular community. And so as we're looking at this and moving through some more of the direction that we're hoping to go, we're going to start making that distinction between intoxication management, which is really kind of that first point, helping that individual to detox essentially from that particular substance that they have ingested, and then moving into withdrawal management, right? Which for this intent, no longer actively intoxicated, really looking at making that connection and facilitating a rapid connection to medication-assisted treatment and that transition into hopefully the treatment sphere going forward. So we'll work on making that language part of our vernacular and that distinction going forward. So for this particular one, we've had a lot of discussions or a lot of concerns around the medical director requirement. And I know, you know, as we're talking through this, they're moving into the 4th edition of the ASAM criteria. There were a lot of questions around, you know, adding a medical director requirement to certain levels of care. What is the intention of that? What does that look like? And I think for the purpose of where we're at today, I want to flag that there is still some work to be done with this one. And what we're trying to do is to take all of these different parts and pieces and requirements, align as closely as we possibly can with the intention of the 4th edition criteria, but also operating obviously within Colorado specific statutory needs. So we had some solid feedback from an event a couple months ago, really kind of connecting this back to scopes of practice in Colorado. And I will say right now, we've not had the time or the ability to do that deep dive into looking at Colorado specific scopes. And so we're not prepared to have that in-depth discussion here today. But I want to flag this to make sure that it is known that this is part of what we will be focusing in on sooner rather than later. Once we have this unit stood up to be able to support this, is really looking at, here is what ASAM considers to be a medical director. Here is what all of our options are in Colorado. Here is how this may or may not align with some other existing statutory language or definitions that we have in our provider rule, right? The last bullet that we have here is, right, professional person. We're pulling in statutory requirements and definitions from 2765 designation. So really doing a deep dive into this to see what parts align, what parts do not, and then being able to come back with, this is the direction, this is what we're seeing, and this is what we think would be a qualifying individuals or credentials that would qualify as a medical director. Help us look at this, right? I'm seeing some comments here, right? Really looking at zooming in on, right, what a specialty in addiction treatment might mean. And that's something that we will look at together and to figure out how to codify that. It does have some expectations in ASAM that really work through reasonable efforts and having competencies that are available for consideration, because one of the big concerns that we've heard is that our workforce might not be able to support this. We want to start by aiming for the standard that we can get to and continue to have this conversation and to revisit that as we really zoom. Those expectations would be, how do we get closer to it with all of the steps that we're taking. So I'm going to go ahead and move into kind of walking through our aligned treatment continuum options that we envision putting forward into this period of transition. So I want to qualify this by saying that this is not an exhaustive list. The next page is not going to be an exhaustive one as well. But what we have here is the most likely options, or the ones that we believe would be the most relevant for this particular group. So keep in mind, as we are looking to make this transition into the future, that really, as a provider, you can pick any level of care that you would want to provide, as long as you're able to meet the standards that are within that level of care. So there is no hard and fast. If you are a 3.2 withdrawal management provider, that means you have to be this, that means you have to be that. We're going to have the menu of options and the different pathways that you can choose to take. And then it would be selecting which one is the best fit for your agency and the direction that you would want to go for your community. So the levels of care that we have listed here are some of the more relevant treatment continuum options. So level 1.7, that is similar to our level 1 withdrawal management, which was recently added to our updated provider rules a couple of years ago. This will be medically managed outpatient treatment. Level 2.7, that is a lateral move from a level 2 withdrawal management, so ambulatory withdrawal management. Those are both medically managed levels of care. where essentially the treatment planning is guided by medical steps. So then the 3 treatment continuum options we will have to select from going forward are going to be 3.1, 3.5, and 3.7. And this is where most of our energy will be spent as we walk through this afternoon. So 3.1, that is that low intensity residential treatment. And for the purpose of looking at this kind of high level and making a comparison between 3.1, 3.5, and 3.7, for this one, we are anticipating that intoxication management, again, that IM language that we're using here, and that withdrawal management is available by care coordination, not necessarily required to be on site. Level 3.5, that is that high intensity residential treatment. This is one of the levels of care that is more significantly changing in the sense that it will have a requirement to have intoxication management protocols on site, as well as withdrawal management protocols on site. And we'll go through a little bit more of what we envision that looking like. And then 3.7, that is medically managed residential treatment. Same thing, we're going to have intoxication management and withdrawal management embedded within that residential level of care and with the ASAM criteria requirement. Okay, so moving from there into our other option, or the other kind of crisis space that we're looking at, making sure we have these services embedded to support our state. These are the aligned crisis continuum options. So same concept applies. This is not exhaustive. This is not all of them. We are selecting the ones that we would be most relevant for this particular group to talk through today. So walk-in crisis, we're envisioning that to still be a standalone service, right, to do screening, triage, and placement as they currently do. We are looking at a crisis stabilization unit, which we'll talk through here in a second, which really envisions modeling behavioral health services in a crisis space, working away from that bifurcation of mental health and SUD by merging the expectation of ATU, acute treatment unit facilities, and crisis stabilization services into one provider type, but being able to have MAT initiation readily available. And we'll talk through that here in a second as well. And then the last crisis continuum option that we're highlighting here today, the name is yet to be solidified, but for the purpose of what we've been talking about, we've referred to it as a behavioral health urgent care, behavioral health crisis center. This is meant to be that that provider type that can support immediate needs, potentially that walk-in crisis plus CSU plus withdrawal management that we've talked about up until this point, really conceptualized as able to receive individuals 24 hours a day, provide that crisis stabilization service in a bedded facility, able to handle intoxication management, and also have MAP services readily available. And I'm going to pause there because I know I've been talking quite a bit and I do see a little bit of a flurry of messages. I'm going to check in with you, Mel. Is there anything that we need to come back to right now, or should we keep going and then we'll come back?
I think for the most part, we've been able to answer them in the chat, either through myself or Jen over at HICPUF. Thank you, Jen, for helping out. So I think we can keep going with this at the moment.
Beautiful, thank you. Okay, so let's start with the Aligned Crisis Stabilization Unit, as that is one of the bigger considerations that we're bringing to the table here today. So what we're looking at here is over time, distinctions between crisis stabilization units and our current acute treatment units have really diminished, right? There used to be a much more significant bifurcation or distinction between the two. There were length of stay requirements, there were certain things around services that are being provided. And certainly as our rule volumes and our expectations have evolved, that's become significantly less. Even to the point where we've had some inquiries over the past few years about kind of some non-traditional approaches or something that wasn't necessarily an easy path to licensing in our rule, right? ATUs that were interested in providing MAP services and what might this look like, right? And so really kind of getting to that point of recognizing that ATUs and CSUs provide very similar services with some slight nuances or slightly different approaches. But the bottom line is they're both providing behavioral health crisis. They're providing this immediate need for communities that needs to be replicated and available. And so what we are proposing here is revisiting the idea of collapsing ATUs and CSUs into one endorsement and provider type, with the intention of being able to support behavioral health crisis, whether it's a substance use disorder situation that brings an individual there or a mental health crisis, making sure that we can equip the facility to be able to handle both. Part of the why for this, I know this was something that this was started a couple of years ago with the updated provider rules as well. But at that time, the timing didn't seem right, and there was some feedback around that transition that it didn't fit right at that moment. Where we're at now, we are at a really organic point of transition. We have a number of things that need to shift across the state in order to align with this 4th edition standard. And so we're going to be looking at a lot of these things in detail. We're going to have to revisit rates. We're going to have to do a lot of that to make sure that the state is set up in a sustainable model. This is looked at as an opportunity to simplify where we can, right? And then really build out where we must to make sure that the state is supported in having this, prioritizing this crisis stabilization unit to ensure that communities are supported. This also supports the idea of reducing bifurcation of mental health and SUD, so that we can have individuals know that they can go and receive crisis services without having that distinction of this is primarily mental health or this is primarily SUD. We want to equip providers to be able to handle both. So part of the how that we're envisioning to get there is including that basic withdrawal management capabilities. And again, going back to our language and what we're trying to get to there, this is particularly that access to MAP services for all CSUs. So one of the things that we're mindful of and we want to make sure that we're connecting with, and again, going back, I think, to some of the connection points that we have with the Transition Ambassador Program, right, for keeping an eye on our scope that we have here, both by provider and by county. As we're looking at this, we're aware that we have some ATU-only providers, we have some CSU-only providers, we have a handful of providers that are already licensed to do both. And so as we're looking at this, recognizing that the transition might be a bit different depending on where a provider is moving to and from, and we want to be, we want to help walk through that path as well. So 5 providers are ATU only currently. We have 5 providers that are CSU only currently, 4 providers that are doing both. And then as we're pulling in, making this option available for 3.2 withdrawal management providers who might consider transitioning to one of these crisis services, there are 33 providers across 21 counties that we will be monitoring to make sure that we can move this forward. So let's go into our physical plant concerns, because I think this is another one of those questions that will keep coming up and has been is a very significant concern, because we're talking about construction. We're talking about facilities that are leased and permitting timelines, and we've heard that loud and clear that there's a lot of concerns about what will that physical plant requirement look like. So we have a number of current limitations that we're looking at, and I have a couple referenced here just kind of to give an example of where we're at with some of these current state and the direction that we're hoping to go. The limitations that I have bulleted here are both from provider rule. So residential services, 2.26, there's expectations around, number of bathrooms and how many bathrooms are required per number of individuals that are served. Going into the crisis sphere, we have ATU services that have some more kind of nuanced and detailed expectations, right? Maximum of 2 individuals based on square footage requirements per bedroom and things like that. So the bottom line that we want to make sure our messaging achieves here, a lot of these requirements are not explicitly statutorily bound. We are able to review them, and we want to work on them with the provider community, especially as we're looking to make this transition, recognizing that this is a huge barrier, or this could be a huge barrier for a number of our 3.2s in particular that might be transitioning into the crisis space, really needing to know what this can and should look like. The trick with this is going to be, in particular, as we talk about how do we manage a milieu like that, that's able to handle somebody who is actively intoxicated or withdrawing from a substance versus somebody who's having a psychotic break. We want to make sure that we are respecting the dignity and personal integrity of all individuals. So we don't have a simple answer today of this number of bedrooms per individual, this number of bathrooms per individual. This is how this needs to be handled today, because part of what we want to be able to do is to continue to build this endorsement type and this system in a way involves providers and involves the unique spaces that we have for a lot of our provider community. So our intention is to build upon the existing living space assignment approach that we have in our existing provider rule. And just kind of revisiting that, we built in some standards that lean a bit more into the physical makeup of the facility, because a lot of our substance use disorder provider facilities are unique spaces. And saying something as hard and fast as you need to have a sight and sound barrier and X, Y, and Z just really didn't work for a lot of those facilities. But there are other solutions and other options that could be creatively implemented to manage the milieu in a way that respects the individual's dignity, that still manages it safely, and ensures that person-centered trauma-informed care can be delivered. And so we do want to continue to build on that as much as possible, and considering all of the relevant factors that we're able to build in: age, sex, presenting issue, management of the facility, knowing that you would have potentially different presenting issues. So with that, I will say the one area that as we're moving into this period of drafting and really coming back with bulleted, here's exactly what we're moving into or what we're proposing, and then being able to have continued engagement with providers of this is possible, this is going to be a challenge, things like that. Seclusion room requirements are not that we are currently looking at or anticipating that would be changing. And keeping in mind, especially because we have a number of providers that this might be the first time that they're looking at considering transitioning to a crisis stabilization unit. You do not have to have a seclusion room. That is going to be something that would be optional. And that is something that we would want to work through and make sure that you have a solid understanding of those expectations before committing or choosing to do that. But those particular requirements are not ones that we would anticipate to change, as those have been strongly vetted for a number of years. So the end goal with that is we want to lean into what exists, recognizing that the goal would be to really minimize risk with the space that is already occupied, and acknowledging that we have very unique facilities that the construction or different, there might be some other barriers that are outside of our control that we want to be able to acknowledge and to work individually with those providers to see how close can they get and how can they utilize their space to minimize risk for individuals served as much as possible. Okay, so continuing, and I'm going to go ahead and try to change my tab here. And before I do this, what I have right here is a draft of a table that we will, we're trying to get it into a digestible format so that it could be hopefully something that you could download and review without it being too gigantic. So we might be dividing it up into multiple, depending on how this goes after this. But the intention with this is to walk through what we have broken down so far. If there are different columns or expectations that we need to add in, we will do that. And then we're hoping to include that with the follow-up email that we'll send to all registrants after this event, as well as have it connected to the slide deck posting. So please keep in mind that you will get a copy of this clearly in draft form once we are done with this today. All right, I just transitioned over. Can you all see that okay? It's a Google Sheet. Okay, thank you, Lori. Okay, so the levels of care that we have kind of pulled up here, this is, our hope is to walk kind of row by row across these, going through the different columns that we have here to ensure that we're walking through some of the main questions that folks had and trying to answer the questions as best we can as we get there. So I'm going to start with, let's go ahead and start with 3.1. We'll go through the treatment continuum and then move into residential. So again, in the future state, this is a pretty lateral move. 3.1 in current state moves over into 3.1 pretty laterally in the 4th edition. This would require a BHE license, as it currently does. 2765 designation, not required, it's currently not. Same thing with the controlled substance license, we don't envision that being part of this. Medical director is not something that is required for 3.1 as well. And again, with this, this is trying to find that sweet spot between alignment with 4th edition standards, but also building something that will make sense for our state and ensure that individuals have proper care options available. So one of the things that we need to care for, and we're figuring out exactly what we want this proposal to be, is what facilities would be approved treatment facilities and able to hold an ECIC endorsement. So for this ASAM level 3.1 residential provider, that endorsement would not be required. Somebody could certainly opt into that. That would be something that we could look at. Actually, they back up. I don't know that for sure. So let me say that that is not something that would be required. That is, we have, we're not envisioning intoxication management protocols or that immediate connection, on-site connection to MAT services being available on-site. That would be essentially achieved by utilizing the crisis services. If something like that were to be of a concern, they're able to work through care coordination with the crisis space that we're talking about here as well. So with that, moving into column M, where it talks about 24-hour urgent care drop-off, that is having essentially a sally port where law enforcement would be able to drop somebody who is actively intoxicated and needing some intoxication management. That is not something that is envisioned or required to be part of the 3.1 level of care. So then, just because we have some training requirements, and I think this is where we'd have some room to build this up before we send this PDF out, at least as the draft that it is. Crisis professional training not required, and we would really build on our standards that we have for currently group living workers, moving into allied health staff being able to provide milieu management of this 3.1. Okay. Let's go ahead and we're going to go into row 8, which is, again, per 3rd edition standards, the ones that we would most likely see here. This is current 3.2 withdrawal management and ASAM level 3.5 in current state. In the 4th edition, there is only that level 3.5 that would be able to provide the following services. So BHE license required, as it currently is. 2765 designation, not required. That's not a change from where we're at right now. Controlled substance license, and again, for this particular license, this is something that allows your agency to be able to store stock medications that can help in the treatment of substance use disorders and withdrawal management. In this case, we would say for 3.5, this is highly encouraged, and I know Ryan, our state SOTA, is always willing to engage in these conversations and to figure out what makes sense for the services that are being provided. So highly encouraged for that, but not something that we would have as a straight requirement. With that said, we would want to make sure that there is rapid access to MAT services. Again, and wanting to support and make sure that's part of the base expectation. So that's part of the sustainable model that we're building, that MAT services are prioritized. Medical director is required per ASAM in the 4th edition. And so this is going back to some of the work that we have to do to really crosswalk the expectations that are permissible there, what is permissible in our state, to be able to come back with a really solid list of this is what we think makes the most sense, and then to be able to engage with the provider community to figure out how we could get close to that. So then our moving into the ECIC endorsement and it being that approved treatment facility to ensure that emergency commitments in particular can be honored. This is another one we want to figure out how to make it desirable and highly encouraged, but trying to figure out that stepwise approach to make sure that we can support the state in this transition. That is one that we have as highly encouraged right now, and we want to make sure we can, try to make that one desirable for you all. Intoxication management protocols and that withdrawal management protocols on site, again, per ASAM, we are aligning with that. And so the expectation is not that a 3.5 provider would begin accepting our urgent drop-offs in the middle of the night. It would be if an individual is determined to be appropriate for that level of care, that you would be able to essentially admit and allow the individual to stay there with the intoxication management protocol, and then they would be able to stay for residential treatment. Same thing, they wouldn't necessarily need to be removed from the facility if there is intoxication management that needs to happen mid-stay. And then crisis professional training, not required here. So again, just building in that ability to handle intoxication and withdrawal management needs on site for the 3.5 level of care. Okay. All right, so then let's go ahead and walk through these last couple ones here. And just doing a quick time check. I'm talking for almost an hour. I'm sorry, this is a lot of me talking, and hopefully we'll get through these and then be able to learn a little bit more about HMA and then come back for some more. So moving into the crisis space, one of the endorsements that we wanted to walk through today is really this crisis stabilization unit concept, where it will be BHE licensed, right? That's already part of a requirement. We do have an expectation that this would be 2765 designated, and one of the efforts that we have in place and that we want to make sure that we have the ability to do is making that achievable and well understood for providers who have not considered a designation before, or if they have our 3.2 withdrawal management or considering crisis stabilization unit services. We want to demystify what that 2765 designation requirement really means, so that just hearing that, if there's any concern about what that might mean for your services, that we can truly help coach and train to see what that expectation actually looks like in practice to make it more approachable. In practice, ATUs are already required to be 2765 designated, so that's a pretty lateral move for them. And most of the crisis stabilization units are, although not required to be 2765 designated, are in practice. Controlled substance licensing, again, that ability to have medications to assist with withdrawal management available from stock on site. What we're envisioning here is that this would be required unless the facility is equipped with some method of same-day MAT services, and making sure that that access is immediately present for individuals who are being treated in the crisis stabilization unit. Moving into the approved treatment facility with EC and IC endorsements. I will say with this one, there's a number of, out of all of the columns that we're looking at here, this is one where we have more conversations to come to make sure that we're truly setting this up in a way that is truly looking at where and how these approved treatment facilities need to live. And so we will definitely be looking at this and let you know if anything changes here, but this is kind of our starting point of trying to move the state forward in this direction. So for that, with the CSU, we're looking at having that be highly encouraged, but not required at this point, with the expectation that it would be intoxication management protocols and those withdrawal management protocols available on site, right? If you are, if the agency does choose to be ECIC endorsed, that we would have required intoxication management protocols on site. Again, right, acknowledging that if an individual required that type of service, that you would be equipped to be able to handle it. And same thing with this, where it seemed like a step too far with making this transition to require all crisis stabilization units to be able to accept law enforcement drop-offs. That's not something that is currently in place right now. It would be nice someday if we could get to that point, but having this kind of interim step that could really operate in tandem with a walk-in crisis facility and be able to receive individuals who require crisis stabilization unit services, but not necessarily changing the model to be able to accept drop-offs 24 hours a day, things like that. And then last but not least, and then I see that the chat's been getting active there. This kind of this endorsement that we're hoping to build that would really be able to support anything and everything that would come into that would cross its path in the crisis space. Behavioral Health Crisis Center, so behavioral health entity license required, 2765 designation required. Again, we want to make that demystified and approachable, and that's something that we intend to do. Controlled substance license, similar to the crisis stabilization unit. That would be required, again, unless the facility had some immediate access, same-day access to MAT services. And then medical director requirement, again, making that lateral move of leveling up the services and the oversight to ensure that safe services are rendered. So this is where we're envisioning that ability to handle, accept and place EC emergency commitments would be at this immediate juncture and when we're trying to make this transition. Again, because a lot of what we're picturing with this is a lot of our 3.2 withdrawal management that currently handle the majority of our emergency commitments would be well equipped to be able to make this transition into that type of provider, already having intoxication management protocols available on site, really making sure that we have that immediate connection to medication-assisted treatment services. They're already equipped to work with law enforcement and ensure that individuals are able to be placed there instead of ending up in an emergency room or potentially in jail while sedated. And then one of the transitions there, or the levels up that we would need to do is around training to make sure that there is, the crisis professional needs are satisfied, recognizing that this would be fully settled in the crisis space. Okay, we are at 1:02. I know we have until 1:30, and I do see a lot of questions are being asked and answered. Go back to our slide here. So I think what I might do, if it's all right, is I'm just going to wrap this last slide here and then revisit to see if there's any discussion we need to have. We'd like to leave at least 10 minutes for HMA to be able to come in and wrap up this connection to the support that they're going to be able to provide over these next few months for our 3.2 withdrawal management providers. So coming back to the questions that we still had outstanding from last time. So transition timeline needs to be revisited. We are doing everything that we can to revisit that, and would definitely love to hear your thoughts around the proposed updated timeline that we are looking at with really doing the full stakeholder work in the fall with essentially not moving into the delayed enforcement period, but just looking at this this option of transition on July 1. Would love to hear about that. Logistical barriers to alignment, we're continuing to get some information about that, but really, again, leaning into wanting to have the physical space that providers are already in. We want to find a way to make that work if at all possible, and really working on elevating the individual's privacy and dignity there. So one of the questions I know I saw somewhere in the chat, and I did not see if it went answered or not, but just this is one where we had flagged there are some questions and concerns around IMD and how it may or may not be applicable, and wanted to flag that that is something that we absolutely intend to look at in more depth. And if that question was not answered in the chat, please know that this is one that we are looking at and we will have more information about as well, but this is on the radar to be reviewed. And then walking through some of the other questions that we had. Oh, I see Mel. Go for Mel.
Hi. Actually, while we're on that topic, if we could park for just a quick second, the IMD question was brought up by Sandra. Sandra said, will IMD bed limit change to accommodate the merging of CSU and ATU endorsements? And Jennifer Holcomb with HICPUF said that she would be happy to give a quick little bit of information about that. So if we could just pass it over to Jennifer while we're on that topic.
Sure. So Zach did drop a couple of resources in the chat. One is specifically a HICPUF source that outlines and gives a good overview of what an IMD is and the rules that apply. And Zach is correct. The federal government, CMS, defines and outlines what constitutes an IMD. So any facility that is more than 16 beds where 50% or more of the individuals being treated in that facility are being treated for a behavioral health diagnosis, which could be SUD or mental health or a combination thereof, meets the requirements of an IMD. Being an IMD, literally you need to tell us how many beds your facility has, and based on the number of beds, if you're a behavioral health facility, then you're designated and we count you as an IMD facility. Because we have an 1115 SUD demonstration that allows Medicaid to waive. There's a federal restriction and limit about what can be covered in an IMD. And so the reason our 1115 waiver is so important to us is that waiver waives the limitation, which is a 15-day limit. If you exceed a 15-day limit and you do not have a waiver in place, then the entire stay, including the first 15 days, is not reimbursable. This is what makes the 1115 waiver so important. It is the mechanism that allows us to pay for those residential SUD services. And just because your facility is an IMD does not mean we count the number of IMDs we have and we count the services provided. But if you are delivering SUD services, the waiver allows us to reimburse you, and you do not need to be concerned about that particular limit. Does that answer your question? I hope.
It does. Yes. Thank you so much.
Okay.
Thank you, Jennifer. I love every time you explain that, because I feel like it is something that the more I hear it, the more I start to understand it. So I do think this is one that does keep coming up. And one of the things that HMA is going to be helping us with, right, is getting some of these FAQs, frequently asked questions, to be able to put these together in something that is tangible and will be applicable to a bunch of different questions that we have out there. And so this is absolutely one that we want to make sure that there is an FAQ around this. So we're in the process of doing that. I just did a quick glance, and it looks like most of the questions were answered in there. Mel, is there any other chats that you had kind of floating out there that we want to discuss before we go over to HMA and see what they're going to be helping with?
Sure. I was just working on a response for Kevin Robinson. Hi, Kevin. Kevin had some feedback. He stated, given the immense cost of hiring a medical director and the relative dearth of addiction med physicians, would the state entertain the idea of requiring the RAISE BOSSOs to provide medical direction directly to providers? If providers could rely on the state for that service, it'll be a lot more manageable for small, medium providers. This is an idea that we have not discussed, so we will need to take that feedback to our team and see what the feasibility is, given the state budget crisis and everything that we're in. So it will be something that we will have an answer for you in the future, but I don't have one for you right now. And then Eli Walker provided that he is happy to troubleshoot with anyone struggling to find a medical director because he is a board-certified addiction medicine physician in the San Luis Valley. Dr. Walker, thank you so much for putting yourself out there to everyone. He's provided his email in the chat. So I just love it when our community supports each other. Thank you. And then I think we have answered or addressed everything else. So I will hand it back over to you, Mariana.
Thank you, Mel. And again, going back to this, we know we had some things that we were able to answer today, and there are still some unknowns and a lot of work to be done in these next few months and a lot of communications that will need to occur. So please, Dr. Rob, I appreciate seeing the kind of wrap up that you had there of, yes, we do want to make this work. We want to be connected. We want to make sure that we're recognizing that this is a lot, and we want to do this in a way that is going to be successful for the entire state. We all have the same end goal, hopefully, of providing good care and improving our system. And we really appreciate you partnering with us to make this happen. Okay, so with that said, we have a wonderful opportunity to be able to introduce our Transition Ambassador Program, which is being run by or provided by Health Management Associates. This is a partnership with BHA and HCPF to identify particular providers, the 3.2 withdrawal management community, to ensure that there is sufficient resources, recognizing the, you know what, I'm actually just going to stop there because they're going to introduce it better. So with that said, I'm going to go ahead and hand it over to Angie to tell us a little bit about the Transition Ambassador Program.
Thank you, Mariana. Good afternoon, everyone. Really appreciate being on the agenda today. And we are so excited to kick off the Provider Ambassador Program in conjunction with both the BHA and HCPF. So as Mariana mentioned, I'm Angie Bergerford, and I will be leading the HMA project team along with Sarah Hodgson, who is the project manager. So for those of you who are not familiar with HMA, we are a national consulting firm who, as as you can see on this slide, has been in the healthcare industry for 40 years now. So we are celebrating our 40th anniversary. We have multiple locations across the country, including a location in Denver. Although the team we have assembled for this particular project comes from across the country in order to make sure we have provided you with the depth of experience and expertise that the state was looking for when it comes to ASAM criteria, as well as assisting providers with adding or transitioning levels of care, or adding or transitioning to different service models. So fun fact here, HMA has supported the state of Colorado for several years in a variety of different reform efforts at both BHA and HCPF, and we are thrilled to continue working with the state now as part of the provider ambassador program. So I'm actually located in the Columbus, Ohio office, but have worked with both BHA and HCPF for the past 3.5 years. And Sarah Hodgson has supported multiple projects over the past few years as well, including the HCPF Training and Technical Assistance Project that just wrapped up last fall. Also, the balance of the team that I will introduce here in a couple seconds has developed trainings as part of the TTA project as well. So we are all very familiar with providing training and technical assistance to Colorado providers. So Dr. Alfonso, who is not able to be on the call today, she is located in the Baltimore office. She has over 20 years of experience in specialty addiction medicine, behavioral health integration, and quality improvement. So thrilled she's part of the team. Debbie Witham, who is on the call today, is located in the DC office and has experience with the delivery of both mental health and substance use disorder services, and served as both a managing director and a surveyor with CARF. And then we also have Rachel Johnson Yates, who is in the Indianapolis office. She brings a state lens to the work, is a licensed mental health and addiction counselor, and has extensive experience as well in program design, implementation, and oversight. And then we also have Lori Stolen, who rounds out the team. She's located in Colorado. She will be the state SME and has a deep understanding of the intersection between behavioral health and other systems, and supports serving those with behavioral health needs. So this is the team that will be supporting you over the next few months as part of the ambassador program. Okay, next slide. So this is a high-level summary of the program. And so really want to make sure that, we are keeping the focus specifically on current providers of the 3.2 WM level of care, and assisting all of you with the transition to the ASAM 4th edition criteria, or to a new service model that Mariana has described earlier in the presentation. So the program will provide a variety or a comprehensive suite of resources, which I will get to in just another minute. So if we can move to the next slide. Okay, so in order to be able to inform the development of the program and the types of tools and information and resources that need to be included in the suite of resources, the HMA team performed a landscape scan so that we could bring the best materials and resources to the table that are most beneficial and helpful to the 3.2 WM providers. So as part of our landscape scan, we reviewed federal and state policies and programs impacting providers. So we did look at waivers, we looked at Medicaid requirements, we looked at what other states were doing. We looked at the Colorado state policies and programs that would be impacting providers. So did a pretty deep dive at both the federal and Colorado specific levels by way of policies and procedures and other areas of impact to the providers. We also compared the ASAM 3rd edition criteria with 4th edition criteria and identified how changes may affect provider practices, service delivery, resource needs, all the way from physical plant changes to staffing requirements. We also participated in listening sessions. So you may have noticed some of us in previous sessions, we were wanting to be able to gather insight and feedback from providers directly, as well as from other community partners, to make sure that we were capturing what would be most beneficial to use in those toolkits, if you will, And we really wanted to make sure we understood the challenges, the pain points, and the concerns that all of you had, and were summarized today by Mariana. And then finally, we reviewed the results from the state's 3.2 WM transition survey, and we're able to get some good information from all of your responses to that survey as well. So we did spend several weeks pulling everything together through that landscape analysis and providing back to the state a summary or memo of all of the findings and recommendations for the program. Okay. Next slide. So here is really the meat and potatoes of what we want to talk through today. And this is related to the training toolkits and pathways that the 3.2 WM providers will have access to. So we will be providing 3 or 4 or 5 different ways of providing information to the providers. The first is a series of pathways webinars. So we want to be able to make sure that we are providing information to all of you about the program. So here's what it is, here's how you can connect to it, here is what you can expect next. Here is how you can ask questions. Here is how to be able to inform the FAQs that we talked about earlier. So we'll be providing that overview webinar as well as a specific webinar for each of the transition pathways. So there'll be 4 additional webinars that talk through the pathways and walk you through the materials that are available for you as you consider which pathway may be of interest to you. We also will be developing training toolkits. So there will be a number of elements or components to each of the training toolkits. So there'll be a provider self-assessment, business considerations. This could be in the form of checklists or self-assessment tools to be able to walk you through different business considerations as you are contemplating the transition to a different level of care or a different service model. We'll provide service delivery model requirements, regulatory considerations. We've mentioned FAQs already, tools that will walk you through the business impacts, the pros and cons of the different pathways. We'll also be providing basic information around Medicaid reimbursement, payment processes, and then what we're calling tips and tricks. So things related to some of the administrative processes, if you're not familiar, for example, with navigating changes in enrollment with Medicaid, for example, or adding or changing licensure approvals or endorsements. So I want to be able to pull materials in there. We'll also be providing a compendium of additional resources that I wouldn't say are more remedial, but provide a lot of good background information and drill down into some of these topics as well. So that will be available to all of you. Then we also have an opportunity to provide additional recorded training modules on things that we have observed might be helpful to providers as you're working through your decisions. So, and these are just examples of things we thought would be helpful, but certainly we'll be working with the state to pin those down and also taking into consideration any additional feedback you might have from the state moving forward. So introduction to ASAM in the 4th edition. I know there's lots of materials out there already, but thinking about establishing kind of a baseline in the context of this program, best practices for implementing the ASAM criteria, and developing quality metrics and looking at evaluation and utilizing self-assessment tools to measure program effectiveness. So these are just a few ideas that we're going to be considering, but again, take these as examples at this point. And then also we'll be providing later this spring office hours where folks can come and ask general questions about the toolkits or about any of the levels, about the 4th edition criteria, for example. So really want those to be open to all of you where you can come and ask questions. And at this point, we aren't envisioning that we'll have particular topics teed up unless we see otherwise, but really want this to be time for you all to come with your questions for us. And then also, and this is what we're very excited about as well, being able to provide one-on-one technical assistance with your organizations, where we can, we'll have an opportunity for you to kind of raise your hand or sign up for direct technical assistance with the HMA team, tailored to what you might be specifically experiencing as you're working through the toolkits, or as you're considering which pathway or pathways you want to further explore. All right, next slide. And for the time being, we are asking that if you want to connect with us short term, if you want to send a note to the HICPUF _SUD benefits at state.co.us, they will get you connected to us. We will be putting out a communication with information on a direct email to us, when office hours are, when we will have the webinars. So we would like to, in the next couple weeks, put out a comprehensive communication that includes all of this information, plus how you can request direct one-on-one technical assistance, how you can ask questions. So all of that information will be coming to you shortly. And then also, if you wanted to learn more about the 4th edition of the ASAM criteria, there is a link that the state has provided here with some additional information. And then they've also provided how to stay connected to the BHA. And I know earlier on during the call, you mentioned the link to the laws and rules, as well as where you can provide feedback on those rules. So hopefully, Mariana, I have covered those additional resources, and happy to turn it over for you to provide any additional detail on next steps that I may have missed.
Awesome, thank you. No, that was beautiful. Yeah, so we're very excited that this is coming to fruition, and with, I think, the proposed the timeline shift that we're looking at here, I think this really does support the work that HMA is going to be able to provide a little bit more than what we would have had before when we had the more rapid timeline that we were looking at. So I'm hopeful that folks appreciate it, or think that proposed shift to timeline would be helpful here. And again, definitely open to hearing about that if people really support that direction and want to move there. We're very excited to see this finally come to fruition. So I think with that, I started to go through and tried to catch up on some of the chats. The team did a great job of doing that, and we'll have written record of all of these comments to move them forward. One of the comments that I do want to highlight, again, really appreciate the feedback around our starting point with the ECIC, and coming back to say, this isn't vetted. We need to really look at this from a different lens. And we're absolutely going to do that. So thank you for bringing that information back. Our hope was to have something that was solid enough for that definite of a reaction, so that we could look at it and then help to really drill down onto exactly what will make sense for the state going forward. So as far as kind of wrapping this, I know we are at 1:25. Again, just to remind, next steps for what we have on our side is we will be transitioning this over, this recording, onto the BHA Laws and Rules page, which has already been dropped into the chat. We're going to include a copy of the slide deck, and we're going to clean up the draft of that proposed table. Again, being very clear, that is a draft. That's where we're starting right now, and we expect that will continue to evolve over the next few months, and then lead into our actual rules that are being drafted, and move forward from that point. So we do not want to lose connection with you all, but this will give us a good opportunity to be able to take this feedback and really bullet it out in a way that will hopefully make this a bit more tangible and allow for more direct feedback like we received today. So thank you for that. With that said, we will be emailing everybody this information. You can always keep an eye on the Laws and Rules page. Knowing that we have 4 minutes left, I will open it up in case there are any kind of last minute thoughts, questions, concerns, feedback that anybody wants to share before we break.
I have a quick question, Mariana.
Yeah, Sarah.
And I'm sorry that I'm super late. I actually just got off with the raise about looking at contracting at a 3-1. versus a 3.5. And they will not give us a contracted rate to make those decisions until we've been licensed by the BHA at a 3.1. But I'm not really sure that I want to commit to that until I have that information. And I was hopeful that you might be able to provide some guidance.
Go for Jennifer.
Yay, I knew this was the right meeting to like try to hop on last minute after I got off that other meeting.
Yeah, it's completely impossible for the Rays to have any conversation with you about future state of ACM4 because we haven't had the discussion. And today is 3.1, and if you get licensed as a 3.1 today, then the Rays can talk with you about contracting with you as a 3.1 provider today. Future state, when we're talking next July, the process is the discussions we are having today inform what the new credentials are going to look like from the BHA. And HCPF is partnering very closely with the BHA because HCPF needs to set new rates that we pay to the Rays. So the Rays are not anywhere remotely close to being able to have a conversation about how they'll contract with you because we haven't started the conversation on how we're going to reimburse them. So you're at least 6 months out ahead of where we could even start to have these conversations because we really need to say, here's what the new levels look like. And on the HCPF side, we are starting to take what we know from ACM4 that's published and internally working through not only, okay, so how do we value that set of services, but we have to do all the crosswalking between how we pay the Rays for each of the levels now and what that's going to look like when we get to ACM4. And when we get through that part, then HCPF can start working through with the Rays what that's going to look like. And every year around March is rate setting season when the department works with the Rays to establish what the department is going to pay the Rays for oversight and management of everything. And it's holistic. So it's not quite like, here's this level, here's this service. It's like, here are all the things we're going to need you to do and what it looks like. So here's all the money we're going to pay. And then when the Rays have that money, this is also the time of year that then they work through their contracts with providers to say, what are we going to reimburse for what services? So you can talk to peers and colleagues, and I would suggest you can, potentially talk to peers and colleagues to get a sense of what Rays are potentially doing today in the space, but you really do need to consider what reimbursements are going to look like with changes, recognizing that is all going to need to change because of the new requirements that you're going to need to have for like what your staffing needs to look like and your hours of engaging and all of that. So expect those rates to shift. And I'm sorry that isn't a good and clear answer of what the rate will be, but generally speaking, no level of care is really losing services and requirements. So it would not be my expectation that rates are going down.
Correct. I like to hear that, and it also sounds like the rules aren't going to become finalized and applicable until next year, correct? So we have a little bit of wiggle room, but anyone who knows me knows I'm like, okay, well, it's March. Why do we not have this answer? And I need to know. So thank you.
Yes, but for this year, they're working on their rates for this year with current standards. So yes, for next year, it's probably going to be closer to the first of the year before I think they'll realistically start maybe engaging in that space. But I think we will have a better sense probably by fall, BHA. Does that seem reasonable?
For sure.
Okay.
For sure, right? If we move into that that alternate timeline that we're exploring right now, we would need to be actively stakeholdering the rules in the fall, and so absolutely we would be there. So with that said, Sarah, I think that was a great question, and I definitely heard a solid FAQ and or diagram in there to kind of help us swim lines of what needs to happen and kind of what domino knocks down the next one. So we'll definitely work on that as well as part of our process. So with that said, we are 2 minutes over. So thank you everybody for all of your time and attention and for partnering with us. And we will be in touch through email here very soon. Take care. Thank you.